Yeah, I sprained my back. I was
How'd you
like,
do that?
oh, take a guess. The gym.
Deadlifts.
No, no, it was squats, but like wasn't heavy. It was like my light back off set. I'd already done like a top set. And I was just backing off, and then something just shifted the wrong way. Anyway, mm, happy holidays to everyone, and the very few listeners that will log in and watch and or listen to this. Mind you, our cardiology episode has over 1,000 views on YouTube. The real impressive thing is that we're going to do 2 episodes in the span of a week, which is unheard of. But thankfully we've pinned Peter Stark down, who is a soon-to-be Franska, who's going, mind you, anesthetics very popular. So many questions about anesthetics. Very hard to get someone who's done and doing and or done anesthetics to talk about it. I don't know why. But this is Peter. He is a PG, well, what are you now? PGY 9, and
Yeah.
he's in his final
What is
year
it?
of, yeah, final year of anesthetic training. And we'll have his letters next year, right?
Yeah, and well, a few weeks.
In a few weeks. Now, I can't imagine this episode's going to go for a huge duration of time. Everybody wants to do anesthetics. I don't know why. Why do you think anesthetics is so popular, Peter?
Honestly, I don't know. It's a
You need to sell the specialty.
yeah, yeah. Yeah, I think I don't know. But to start off though, I'll just preface this that
Yeah,
like any advice I give is like very general and likely only really applies to myself and isn't necessarily true at a different hospital or system.
good preface.
I think the popularity of anesthetics has changed hugely. Like when I talk to some of my senior colleagues, some of the guys that are in their like late 50s, maybe early 60s, when they got onto anesthetics, it was like accidental,
Mm,
right? Like they were doing a surgery rotation and happened to catch the interest of some senior anesthetist at the time. And there was no interview, they were just offered a job. Right. And now it's like become some sort of crazy process. Like even when I was applying for training programs, I remember applying for jobs in Sydney, which had kind of 5 positions, and there was more than 200 applicants for that
yeah.
position. And that was some of the independent jobs, which are kind of less popular than the scheme jobs in Sydney. So the popularity's boomed. I don't know entirely what the driver is. I was thinking about this morning though. Like I was a little bit worried that some of it might actually be financial. Um, which kind of like there's two sides to that, right? Like, yeah, there's the side like I think often the public kind of thinks that doctors should be purely motivated by non-financial reasons, and that's kind of what you would say in your interviews, of course, the approach that you'd want to take. But then at the same time, like the cost of living crisis affects everybody, and I think if I was a medical student or a junior trainee now, it'd be impossible not to be thinking about that as well, right? And I imagine that's why there's probably a bit of a move away from a lot of people doing general practice training as well.
Which I'm glad you've said that because I do recall you wanted to be a GP once upon a time. So tell us, we did med school together, and then you went into the countryside. And you were full on, you were just like, I'm going to do GP. What made you change to anesthetics?
Yeah, I don't know if this person still exists, but like I would have considered myself a gunner for GP, which I might have been the only one ever.
This
Yeah,
guy was a shoe-in. He was a
yeah,
shoe-in to GP.
yeah, yeah. Yeah, I don't know what happened. No, so yeah, I wanted to be a rural GP specifically originally, and I think the process that kind of turned me around from that was in my final year of med school. I did a rotation at an ICU department,
Mm.
which I really enjoyed. It completely changed my perspective. So then after doing that, then I was really lucky in that my intern year I got to do an anesthetics rotation. And
Which
we
is
all
pretty
kind of
rare as an intern to even have anesthetics as a rotation at all.
yeah, yeah. So it was like a full term of anesthetics in my internship, which we all do anesthetics, or most of us do it during med school, but I think my experience was like everyone else's, 2 weeks of kind of trying to put in cannulas with somebody,
And and trying to shove
breathing
in an
under me.
LMA. Yeah, yeah,
Yeah,
just put
yeah.
the LMA in, and you're just like, what am I doing?
Man, I remember I found my anesthetics rotation as a med student like terrible. I hated it. I thought it was so boring, and I was just so shocked that somebody would choose to do that career,
Yeah.
right? Yeah. That was as a med student. And then as an intern, when I went back and did it, I kind of had this new perspective that all of a sudden I wanted to do ICU training. And now I was like super motivated for ICU. And then I went to anesthetics. And I was like, this is actually a lot of the same knowledge, a lot of the same skills, but the people seem a little bit happier and
Mm,
they're not warning me that there's no jobs at the end of the training program. Right. So it became pretty obvious that, if you're going to pick between ICU and anesthetics, at least for me, anesthetics seemed more logical.
okay. And what do you think the appeal of the crit care was? Did you like the mental stimulation that is the physiology and the, I don't know, I guess the bio pharmacy or whatever, like you got to think about drugs and doses and whatnot.
Yeah, I think it's all those things plus, kind of the procedures that you get to do, the equipment that you get to use. I kind of saw ICU as pretty cutting edge.
Yeah.
Like I'd spent some time at the Alfred, walking through their ICU and seeing ECMO and things like that. And I just thought it was really cool. And kind of thought that you were always going to be at the forefront of, technology and medicine. And I was interested by that. I think, yeah, other than that, though, I was just having a thought, but I've lost it.
That's
Anyway,
okay. So, okay. If hypothetically, crit care, like there was a huge amount of understaffed ICUs across the state, and there wasn't that, because I've heard this, like when I did crit care as a resident, you hear this all, there's this perpetual crit care fellow who's like on their fifth fellowship waiting for a consultant job to open up somewhere. If hypothetically there was like this abundance of ICUs, because to be an ICU specialist, you need to practice in an ICU. Would you have done ICU instead of anesthetics?
no, I mean, there's other downsides as well. So, like the rostering and the work hours is very different. As a consultant, like as an anesthetist, you generally get to pick when and where you work. You can kind of set your own roster somewhat, depending on what system you work in. Whereas in ICU, it seems a bit more set, like you've got a responsibility to work. I don't work in ICU, and what I'm saying might be incorrect. So
Incorrect.
somebody,
Yeah. It's just what you've observed.
yeah, it seems much more like even when you're a consultant, you'll do week on, week off, and you'll be on call for that whole week. I think some hospitals have changed in that, like if there's the ICU that's quite large with, say, 4 pods, during the day they'll have 4 consultants, and then overnight one of those consultants will do the on call for all of the 4 pods. Whereas I think historically you would be on call for your own kind of pod.
Yeah.
So I think they're becoming a bit more progressive to kind of manage the
Balance out
fatigue a
on
bit
call.
better and reduce the on call commitments. But yeah,
Yeah.
I think the lifestyle that way, the hours and the job opportunities seemed less attractive.
Mm.
And yeah, and the other thing is at the front end of the training, ICU and anesthetics used to have essentially the same training program,
Yeah, there
which
was like there are a lot of like dual trained, you do like an extra year or something, right? But that's not a thing anymore. I think they're separated.
no, yeah. So yeah, like you'll still meet quite a few people that went through that program. It's only I think just over a decade or so ago that it changed. But yeah, since it's changed, there's even though the actual medicine is somewhat similar between the two, and the exams share a lot of similarities still. There's a difference in the way that you kind of step through the rings. Yeah, anesthetics, the bottleneck's getting a job, and then once you've got a job, you kind of make your way through training. Whereas for ICU, you have to have the job, but then
Yeah.
yeah, so there's a lot of ICU registrars that are essentially just treading water prior to getting through that first exam. And it can be all sorts of reasons why you push that exam back, but it can add a significant volume of time to the front end of your training, which is pretty like if you had to pick a time to spend extra time in training, you probably want it towards the end of the training time, right? When you actually have the skills and knowledge. I don't think doing more and more junior time.
Yeah. Okay. So before we get to the program itself, you've come out of med school, you're a GP gunner, and you're ready to make a difference, save lives in the rural GP environment. but now you're pivoting to crit care. What do you do to change your CV? Because I know there are like courses and extra things that you have to do in order to develop a more crit care focused CV and a more competitive crit care application. What did you do?
Yeah, so I think this is one of the areas in particular. I'm sure that your viewers, the people that want to go into anesthetics, will be hugely interested in. I'm worried that they're going to take notes on this and follow it verbatim because
And then not
it's
get
just
on.
like even in the interviews I went in, it was clear that in the interview panel, one person wants something completely different to the person sitting next to them, right? And
Yeah.
that's in the one hospital,
Yep.
one department. So there's a huge variety in what the departments actually want and individual interviewers actually want. What I did, I think what a lot of people do is you kind of try to start doing courses early on. So in your resident years, there's various different kind of crit care related courses like basic, which is a basic assessment and support in ICU.
That's the RACS course, right? That RACS
No,
basic.
administered by the ICU college. There might be a
Okay.
different for you
Maybe
guys.
there's a different one. Yep.
Yeah. This one's just so you start doing some courses like that and ALS and whatnot, and you you start trying to pad your CV with things that show that you're interested. I went down the line of doing a master's of critical care medicine as well, which I started in my internship year.
What did you do that through?
I did that remotely through Uni of Sydney. My take on this, though, is having done it, I wouldn't do it again.
Okay. Good to
Yeah,
know.
quite expensive. And like quite a few people do it. And I don't think it really adds anything to your application. You kind of think that it definitely will, right? Like this is huge. At the time, I was probably one of the few people doing it. I think it's become more popular since then. But like it's a lot of money, and I don't think it actually helped that much. And in fact, like I had people actively tell me, I remember one guy telling me I would actually select the person that doesn't do the masters
Hmm.
because it shows that you want to spend your free time doing medical stuff when you should just be enjoying life. I was like, I've already done the masters. It's too late to
Yeah,
warn me
it's
now.
too late.
You feel
Yeah.
terrible. But
That
anyway, yeah, it's
yeah, you've
expensive.
already sacrificed the money, the time, the effort.
Yeah, it was all already gone, right?
Yeah, okay.
Yeah.
That's rough.
So anyway, yeah, I did that. I wouldn't do it again. I wouldn't recommend it. There's pretty other courses. I think if you were hell bent on doing a uni course, I'd actually do something medicine adjacent. I think a lot of interviewers would perhaps be more interested in there's various masters on
Public health or something.
public health. I'd even do an MBA, and do something completely separate.
Okay.
I think that would be a lot more interesting and potentially give you something different. And when you get further through your career and more into senior positions, it gives you something different to sell yourself with,
Did the
particularly in
content help you as a doctor?
sorry.
Did the content of the course help you as a crit care doctor? Like, there's got to be something redeeming.
What it did specifically for me was, I started as an intern, and then there was, a bit of a delay between when I was an intern and did that first anesthetics rotation, and then got back into, an anesthetics job in the future.
Mm.
So it kept me interested, right? Like, it meant that I was still studying the stuff that I wanted to be involved with, and kept my mind fresh and involved in that area, which it's an expensive way to do that, but for me, I think that was the benefit.
Trying to give the viewers a balanced point of view
Yeah,
in case they've commenced this course and dropped the cash.
yeah,
No need to crush them at this stage,
yeah.
Peter. But anyway,
The other thing is
he did a Masters of Medicine, which helped him prepare, I think, for his BPT exam. So that
yeah. So
coursework, it's different.
that's the other thing. So the exam content in the uni degree does overlap with the exams, particularly the primary exam in anesthetics. But the problem is it's just not to the same depth or breadth. So yes, it does help. I probably did it too early for it then to be kind of fresh knowledge for me to carry into exams. So a number of years in advance. And then if I did it at the same time, it would have been too onerous to do both at the same time.
Yep.
So yeah, I mean, maybe if you time it a bit better than me, it might help a bit better.
Okay. All right. So now you've done these courses. How do you then get a crit care RMO job? I know you had to cast a wide net of applications.
Yeah, so this is the step in the well, the step that I didn't get right.
Hmm.
Yeah, so I was at Monash is a PGY2 resident, and in Victoria at least, it seems like the trend is you either get a anaesthetics SRMO job as a PGY3, and then you get onto the anaesthetics training program the year after that. It seemed to me that you do it that way or you don't get on. So anyway, I was at Monash. I didn't get the anaesthetics SRMO job, and then kind of had to scramble for jobs at the last minute of that year, and ended up moving to Sydney for an ICU SRMO job. Essentially, I found out that I didn't have that anaesthetics SRMO job late enough in the year that everything else had shut as well. So there wasn't really a good backup plan, without that job. I'd interviewed at a few places, but just got unlucky. And then, yeah, I saw the ICU SRMO job as kind of the next best thing to kind of stay in that crit care space.
Yeah. Okay.
Yeah. So, but to try to answer your question, look, I think if I was doing it again, if I was a PGY2, what I would try to do is you want to try to make yourself known to the department. So speaking to people early, and there's got to be a fine balance, and this is pretty true throughout the whole of your anesthetics career. Is there's a fine balance between like being keen and showing that you're interested, and just annoying people and rubbing people the wrong way, right? So, I mean, don't go emailing a department every day or every week for months. I think try to get a recommendation of who a good person to speak to is, and try to find somebody that's kind of open to speaking to, a resident, and then, essentially ask to invite yourself in to join some of the department meetings. They often have either teaching sessions or weekly or monthly meetings. And I think if you kind of get an invitation to go to those and then kind of introduce yourself to different members of the department, at least then you're kind of a known entity and they've, had an opportunity to socialize with you a little bit. And that way, when it comes around, not only will you get tips and advice through meeting these people, but then when it comes around to actually applying for these jobs, then you're not just another name on a CV. You're kind
Mm.
of, you're that guy from that meeting. Yeah, I met you. You seemed
Yeah.
reasonable.
That part of the process, yeah, it seems it's very informal, probably less merit heavy, merit-based heavy. It's slightly more informal. It's almost like they're assessing your fit for the department before the interview anyway.
Yeah, 100%. I think that happens kind of across the board for anesthetics jobs at any level. Even going to consultant jobs, this advice is probably still true. It's a bit of a shame. Pretty one of the downsides of the system, but I think it probably represents that all of the trainees looking for these SRMO jobs are all broadly very similar, and that's true again next year and the next year, and so
It's
yeah,
funny. I think that process still applies to like radiology as well. I reckon across the field, but I reckon at the very least because of the competitiveness of surgery, definitely the colleges push it more and more to be merit based.
yeah, surgery
They've
is a bit
made it,
different with the rubric, right?
yeah, they got the scoring rubric. They do, credit to the college and any of the surgical colleges really. There is a rubric and there is an effort made for transparency, whether you, the viewer, believe it or not. I think
Yeah,
that effort's there, and it's different. Like, but there isn't that in anesthetics. I don't think it exists in radiology. I don't think it exists in pathology.
yeah,
But anyway,
yeah. I
okay,
think
yeah,
Yeah, surgery jobs. I think on the whole, particularly subspecialty stuff, it's more competitive. But yeah, I'd agree. Like it seems more merit based. Like yeah, every year we kind of see unaccredited registrars that seem like the golden child, a shoe in for the job, and then they miss out, right? And
yeah,
you kind of think like they were brilliant and they were well liked by everybody,
yeah, hundred
but
percent.
clearly there's somebody better, right?
Yeah,
Whereas for anesthetics, like I felt like you could be the best in the batch and still just get unlucky.
yeah. You could be best on paper, but maybe you fall short on some of those informal assessments.
Yeah,
Um, okay, so you moved to Sydney for this crit care SRMO job. That's still not training. Because at this point, there's now this divergence. There's the scheme training and independent jobs. Can you explain that to the viewers?
Yeah, so I don't think this applies to every state, and the proportion, the ratio of each of them is wildly different. But essentially, there's kind of a few different tiers of jobs. If you're going for anaesthetics training, it's a few different tiers of jobs. So the best job to be in is a scheme job or like a proper training position. In New South Wales, there would be a 4-year contract. You essentially complete all of your training through the one hospital, and they rotate you out for the different rotations you need. But you've got a home base. And then you do a fellowship year on top of that, so 5 years. But in Victoria, it's more a network rather than a home base, is my understanding. So you'll be in like the Northwest training scheme, and they'll send you to a bunch of different hospitals over your time in training.
Yep.
So that's the scheme job. And then kind of the rung below that is an independent job. And an independent job essentially means that you're on the training program. Like you can pay your money to ANZCA and you can sit the exam eventually, and the time's counting, but it's only a 1-year contract normally. So there's various numbers of these jobs. So in New South Wales, I counted up 1 year, and there was something like 60 odd independent jobs in New South Wales.
Wow.
Whereas in Victoria, I think there's only like 5 or 6 or something.
I mean, New South Wales could just band together and split those 60 independent jobs into 30 and 30 and create them as a scheme. Like, okay,
Yeah,
that's
the issue is
logistical.
the issue is that you can't do all of your training requirements in these jobs. So like the independent jobs generally exist at smaller hospitals and particularly rural hospitals. So places like Wagga Wagga, I think. Or actually, Wagga Wagga, I think, is about to have a scheme position kind of joined with one of the other bigger hospitals. But a place like Tamworth, they would have a couple of independent trainees on a 1-year contract. And essentially, they're just spending their time there trying to get a bit of experience and trying to then apply onto a scheme job.
So you can switch. You can be on an independent job and then enter a scheme.
Yeah. So that's what I did. And then there's very few people that do independent training for the whole training program.
I imagine it would be very difficult to ensure you get all your training requirements done if every year you're
Yeah.
trying to find that next job that fills the requirement
Yeah,
you're
exactly.
missing.
And the problem is like some of the training requirements are things like doing a cardiac surgery term or doing a neurosurgery term. So that only exists at the bigger hospitals, right? And then the problem is the bigger hospitals already have the scheme trainees. So if you are accepted in as an independent trainee into a hospital that's got scheme trainees, you kind of then have to fit within their roster somehow.
Yeah.
So you're not going to have first priority for those terms. So you might actually have to commit to staying a little bit longer. I think if this is very rare. Like very few people complete the whole training on just independent contracts throughout. But yeah, if you did end up in that situation, you would expect it to take longer than 5 years total.
Are there situations where is finishing up a independent job and they've missed out on scheme jobs and they're scrambling for another independent job, or they miss out on, like, what do they do in that situation if they miss out on another independent job?
Yeah, so I think I don't know the numbers on this, but I think it's probably actually reasonably common. So yeah, so your options are either moving forward onto a scheme job or staying in an independent job, or essentially anaesthetics. So I've seen kind of all three. I think a lot of those people that kind of get forced out of anaesthetics probably end up in ICU.
But the college there's no support pathway for the independent registrars who, like, does the college not play a role to ensure that they progress in their training, or not really?
Okay, I'm not entirely sure, and ANZCA is incredibly supportive. Like it's a great college, and so I don't want to say something that's wrong, but my
Yeah.
understanding is they've got no commitment to the independent trainees.
Okay.
Yeah, so it's essentially very similar to an unaccredited job, except your time is counting.
It still count. Like it still. So what if you did a year that counts, then you missed out on a job, and then you come back, 12 months later? Can you restart where you were? Is it just paused training, or these are
I'm
hard
not sure.
questions. If you don't have an answer, that's okay.
Yeah, I'm not. ANZCA for certain has some sort of statement on this. Yeah, there would be some sort of time frame that you need to complete
Finish
things within
training.
and how much time you can take off. I don't know the numbers, but
Fine.
I think the reality is if you missed out, probably you're not coming back.
Yeah. Yeah.
Yeah, it
Okay.
would seem unlikely.
Yeah.
Yes. Yeah, yeah. So it's generally, well, it's different in every state. Each state has a slightly different way of administrating the anaesthetics training program. So I think both Queensland, well, South Australia and Northern Territory are combined into the one training scheme, and I think that's called Sandtrats, and that I think shares a lot of similarities with Queensland, is my understanding, a centralized sort of scheme. You can, yeah, courts. So you kind of apply to that one scheme, and then they figure out where you go. Whereas Victoria, you kind of apply for the SRMO job, and then you apply for the network. So you kind of have one interview for each of the networks that wants to interview you. Whereas Sydney, you apply at every different hospital that's got a job. So I think now they've kind of staggered it in a way where you'll find, at least in New South Wales, you'll find out if you have your scheme job before you have to apply or interview for the unaccredited and independent jobs. Whereas back when I was doing it, you kind of had to interview for all of them at once. So some years, like when I was trying to get on, I think there was a year where I did something like 15 or 20 interviews, like,
Oh,
yeah, yeah, yeah. So I was very good at interviews that year. Yeah, that was
so much volume in practice. Unbelievable.
that was brilliant. Yeah. So speaking of which, that's the third type of job, is the unaccredited job. So there are the odd unaccredited job where you're working in anaesthetics, but isn't actually able to count towards your training time. And you're not able to sit the exam. I think again that's pretty more common in New South Wales and Victoria.
Is that a good pathway to take? Then
Yeah,
do an
I mean,
unaccredited job and then apply to the scheme?
yeah, I think if you've got nothing else, yeah, of course. I think the way I would, I think it goes back to what we were saying before, right, about being well known in the department. And I think it's similar to the SRMO jobs, right? Like it's essentially a 1 year job interview. You're working alongside everyone in the department. They all kind of make a decision on whether you're good or not, and whether they want to keep you around. And then you go to the interview process and they confirm that, right? That's my impression. Yeah.
Yeah,
I don't want to
fair
have
enough.
ants kind of breathing down my neck after saying, "Oh, you."
You've misrepresented us.
Yeah,
No,
yeah.
that's fine. Yeah, it's just what you've observed and what you, I mean, this is your experience. Like you literally lived through this. So once you start training, there's a exam in first year and then an exam in fourth year. Is that right?
Yeah, so you can do, so there's a primary exam and a fellowship exam. You can do the primary exam after your first 6 months in training. So you can do it either, there's 2 sittings per year for both the exams. And so you can, in your first year, you can only sit it in the second sitting. But you can also sit it in the second year as well. If you haven't finished the primary exam in the second year, then you can't progress on to advanced training. And then you'd go on to like a basic training extended sort of pathway, which is kind of like almost like going back on to a probation period. And then, so once you're through that, you go into advanced training, 2 years of advanced training. You can sit it either, you can sit the fellowship exam either in the third or fourth year. I wish I knew, because my journey would have been shorter. There's stuff which is just obvious, and there's stuff that's pretty under the wave somewhere. What we were talking about before in terms of being well known to the department, kind of having all the other tick boxes that everyone else has in terms of courses and things.
Did
So
you do
research.
research?
No, I never did any. So I never did any significant research. That's what I'd say. And I think back when I was applying for training, I kind of asked about research to a few people, and the message I got at that time was kind of, why would you? One of the reasons to go into anesthesia is to avoid research. And I think that's becoming less and less true, and it's definitely department specific as well. So some departments are very academic, and they would find that much more valuable, whereas other departments probably don't care. The thing that I think about is, if you guys ever seen the Medscape articles, they do like an annual review of the competitiveness for different specialties and subspecialties in the US.
Yeah. Yep.
This is something I find interesting, because I could see Australia going down a similar path, but essentially, I read one of these articles years ago, and it kind of said that for the top 3 surgical specialties, it was like op-pharm, ortho, and neurosurgery, that the average trainee had something like 20 first author publications each, right?
Believable.
And and then you realize, like, when they're applying for these jobs in the US, they're still medical students. So
Mm,
what medical student is pumping out, a good quality, useful first author paper?
Publication.
Like, it doesn't
Yeah.
exist, right? Like, all of this has got to be rubbish and just noise in the research world. But anyway, I think that's the way where it could swing too far. Yeah,
Yeah.
people
No,
just
that's
being
true. There's
being
definitely that
approaches
criticism, especially in the surgical world, where research becomes just a means to an end, just to try and
to get the
beef
numbers for
up
the
your
paper.
CV. And
Yeah.
in amongst all that, there are going to be people who are truly passionate about research and are committed to putting out quality research that makes a difference. But a lot of it is exactly what you're saying. A lot of it is noise.
Yeah, so I think the research, kind of has, like for a lot of people, the idea of doing research or doing an audit is not really for the interest of it, or for the sake of publishing something. It's actually just purely to kind of get their name into the department, and then to hopefully go and present that paper at the
Yeah.
department meeting, and
Yep.
becoming a bit more recognized by the powers to be. So yeah, I never placed much value on research. Yeah, apart from that, I mean, it's really tough because, yeah, like we were saying, there's no matrix, there's no rubric like surgery. So it's really unknown what makes you a good candidate. And it really,
Also,
I truly
yeah,
believe it'll be different department to department.
not it's not standardized. As you
No,
say, it's network
yeah,
based, it's department to department. It's not
yeah.
just one college
If I was
administrating
going to
the
give
selection.
guidance, so I think Ansgar kind of has um, a huge number of publications, on its website that are free to access. There's one in particular that talks about kind of the roles of an anaesthetist. Like often you think of an
To
anaesthetist just
obstruct surgical
clinician,
specialties from performing
as
that
in
add-on
the fine
case
print.
at the end of a list, or to start questioning, oh, at 4 p.m., when are you guys going to wrap up? Like, what are you guys going to finish? Like, what are we doing? Yes.
Yeah, no, that's in the fine print for sure. But uh, so like I can't remember all of them, but it's something like 6 or 8, kind of roles of an anaesthetist. It includes things like research and
Mm,
mentorship, and being an academic, and various other non-clinical kind of priorities. So I think if I was looking to apply, if I was somebody in that position looking to apply, I'd be looking for those documents and kind of figuring out what does ANSCA, what does the college actually think makes a good anaesthetist, and then trying to kind of get experience or pad my CV in a way which shows that I've been committed to all of those different facets of what they expect. That's the way I would play the game if I had to play it again.
yeah. Now you're going to be a consultant in 4 weeks' time.
Mm.
What's it look like? What are the prospects? What are you envisioning for your first year as a consultant?
It's kind of, well, I mean, super exciting. Um, been looking forward to it for a while. And, I kind of finished my training requirements a while back as well. So this year I've kind of just been finishing off time, but not actually training requirements. So I've had a lot of time to look forward to it, I suppose.
Mm,
So it's an interesting year because you essentially have a lot of freedom. You can essentially work as much or as little as you want. You've got the opportunity to work across both public and private, all sorts of different hospitals. You can really do whatever you want. I know people that have gone and locumed for the first year as a consultant and gone and traveled around Australia as well.
mm.
So yeah, a lot of flexibility.
And the prospects of public work are there.
Yeah, public work. Well, I found it a little bit more tricky partly because I've used this year as an opportunity to move back to Melbourne. So I've kind of been applying for work in hospitals that I've never worked at. So I'm an outsider.
Mm.
Um, which has made things a bit more challenging. And probably I should listen to my own advice of how to impress departments. But anyway, so yeah, there is public work around. If you've trained in the state, you almost certainly be able to find a job at one of the hospitals that you've worked at. I think Victoria does this really well, where they move you around a bunch of different hospitals.
Yeah.
Essentially, you kind of get known everywhere, and as long as you're kind of a nice person and reasonable, most places would be happy to have you back. The assumption being that there is actually jobs available, which is a little bit outside of your or even the department's control. A lot of it comes down to budgets,
Yeah.
which flux a year. So I think, was it last year or 2 years ago, there was kind of a hiring freeze for public work in Victoria.
Yeah, last year. Yep.
Yeah, so that year there was a bunch of kind of Victorian trainees that moved to Sydney to accept kind of full-time work in Sydney instead. Um, yeah, and I think that year, or perhaps more, in the COVID years, there was people kind of doing multiple fellowships as well. But yeah, generally speaking, like I think most years, apart from those kind of major events, there's jobs available, and you'll be able to find work. And even if you don't get public work, there's private work available. And I think that waxes and wanes as well. But at least at the moment, it sounds like it's easy
How do
enough to
you
find.
how do you obtain private work? Do you have to get to know the surgeon who can then invite you to their list or something?
Yeah, yeah. So I think the former is probably the most common way to find work, and particularly work that you're going to be kind of enjoying and sustain for long term. When you talk to senior anaesthetists, most of them work with surgeons who they are friends with. I don't know, maybe some of that's nature, people that they've met during medical school and whatnot. Some of that's nurture as well, right? You would only remain working with the guys that you're friends with,
Yeah.
I suppose. But anyway, yeah, private groups, definitely a thing as well. Private groups, the way the work comes down to the junior kind of bosses is essentially either a surgeon already works with one of the anaesthetists in the group, offers another list to that anaesthetist. They're not available. Let's say I'll find somebody in my group that will cover it, and offer it to the group as long as the surgeon's happy. Or occasionally, the surgeon's rooms will just contact the anaesthetic group's rooms and kind of say, "We've got
Yep.
this list on this date. Do you have anybody?" So yeah, there's kind of a bunch of different ways that the groups can help. Yeah, or the other alternative, if you're not a member of a group and you also don't know any surgeons or you're not friends with any surgeons that are kind of finished training, then doing on calls at private hospitals where essentially you're available, after hours for emergency cases, and then meetings.
Yeah. Any interest in doing a pain fellowship? You don't want to manage chronic pain? That's tough.
Yeah, yeah, ANSCO, you have to do a fellowship. Yeah, part of the training requirements. Yeah, you can do it overseas. The common ones would be the UK and Canada, occasionally America, but I think much more difficult to organize. And there's a few oddball ones like Hong Kong and Singapore and places like that where you can go as well.
That'd be nice.
Yeah, it'd be super interesting, right?
Yeah.
Yeah, so I think there's a lot of merit in doing those. The guys that do it seem to have a great time and come back with a very different perspective on things. Yeah, that would be really interesting. I think the only caveat to all this is you kind of need to organize those things pretty early on. So a lot of the guys that went overseas that I knew were kind of organizing it more than a year in advance, which relies on you kind of not having the second exam distracting you at the same time.
Yeah.
If you
Yep.
want to go down the path, I'd suggest doing the second exam as early as possible. Yeah. But otherwise, if you don't go overseas, you can go interstate, which is what I've done. And there's kind of different types of fellowships. So there's, fellowships where you actually develop subspecialty skills, like, the most obvious one being a cardiac anesthetic fellowship. And that's the only one which really opens different doors for you. So doing a cardiac fellowship means that you are then a cardiac anesthetist, which is kind of almost a different, well, it is a different skill set, almost a different job altogether. And that's kind of the only way to go and then, work in cardiac surgery in the future. And, that's partly because there's actually exams involved with that, like ultrasound exams for toe and things. And I think also there's probably some sort of credentialing requirement in terms of like numbers of pump cases to actually be able to go and work in that field. The other subspecialty fellowships are, a little bit more of a, I say this too strongly, but they're a little bit fake a lot of the time. So there's things like airway fellowships and perioperative fellowships, all sorts of name a different interest and there's a fellowship for it. The reality is in Australia, there's just not the volume of any of these, specific case types to
Mm.
actually have a dedicated fellowship in that specialty or subspecialty field. So, I mean, if somebody's done a subspecialty fellowship in Australia that's not cardiac, then probably it's more a general
More
fellowship with just
general.
flavor of that, which is like, if you go to Canada though, say if you did a regional anesthesia fellowship, and not regional as in country, but regional as in pain blocks and nerve
Thank you for
blocks.
the distinction.
Yeah, just in case. So, like I did some regional fellowship time in Wollongong where I did a lot of blocks, but
So
not
you did a regional fellowship.
a double regional.
Double
Regional.
regional. Unbelievable.
Yeah, but I did a lot of blocks, but like I wouldn't call myself, a regional anesthesia guru.
Specialist.
Yeah,
Yeah.
yeah, it doesn't really exist. Whereas the guys that, when I went to Wollongong, the guys that I was kind of training under, kind of 2 or 3 guys that had been to Canada and done regional fellowships there, and the setup there, just because the system's different, they've got hospitals that just do high volumes of orthopedics or joint cases, and essentially they'll have this regional fellow just set up in a block room doing the blocks, back-to-back blocks for patients that then go to a different operating theatre to have the surgery, and
Oh,
they actually get looked after by a different anaesthetist in that operating theatre.
you
So
just
your
did
job
doing
will
the
then
blocks.
be the blocks.
Yep.
They do thousands of blocks in that one year.
Yeah, wow.
Just in terms of volume, if you go overseas, there's an
Is
opportunity to really
What
excel.
about pediatrics? Do you have to do a year in pediatrics to be like a pediatric
Yeah, yeah.
anaesthetist?
Yeah. So that's the other specific one that I should have mentioned with cardiac had I have remembered. But
That's
yeah.
all right,
So
man. This is why we host and you answer questions.
yeah, that's right. Yeah. Yeah. So peds essentially, like all anaesthetists will anesthetize pediatric patients during training, and the vast majority will anesthetize pediatric patients throughout their career. The difference is, the complexity and the age range. So the average general anesthetist will go down to age of 2 for kind of well children, ASA.
Yeah.
2 sort of thing, maybe 3, 4, when they get older and more adult-like. But if you want to anesthetize kids under 2, and particularly babies and neonates, preterm kids, or highly complex kids, in terms of comorbidities, or kids for highly complex procedures, then you need to be a pediatric anaesthetist and work at a pediatric tertiary centre like Royal Children's or Westmead Kids.
So trying
Honestly,
to separate pain management from anesthetics. No, I'm pretty sure. I mean, maybe you don't, but I
yeah,
know
so
of another trainee. Yeah, I know of another trainee who will do a pain fellowship. And anesthesia are the ones that do the pain rounds, and they manage the patients with the
yeah.
on the and the what do you call them? What do you call them?
Yeah, we do the pain rounds,
The
and you
button?
pain term during your training.
PCA, patient controlled
Yeah.
analgesia. There we go.
So I think the pain thing. There's a couple of different things in pain. So there's kind of inpatient pain, which is mostly acute pain services, and like majority of the time that's just managed by the anesthetics department. And then at some hospitals you might have a pain trainee from a different specialty. So like when I did my pediatric rotations, there was a couple of kind of pediatric physicians that had elected to go and do pain training. So they would come and do the pain rounds with us. So that's one aspect. And majority of the time that's looked after by non-pain specialists for the acute pain service. It's just anaesthetist.
Yeah.
And maybe the head of the department's a pain specialist or dual, pain anaesthetist. But anyway, and then there's kind of the more chronic pain sort of stuff, which is mostly outpatient or, private work. And that can be, or the chronic pain stuff's I think mostly clinic work, and there's procedural pain work as well, which is doing nerve blocks or putting in stimulators like spinal cord stimulators, or there's also implanted drug infusion devices. And that, I've never actually been exposed to that. That's kind of a different beast altogether, and I can't really speak to it. But I think majority of people that do those, they might have to be, I'm not sure. Yeah, the majority are definitely anaesthetists.
Yeah. Cool. Anything you want to tell us, Peter, that I haven't asked? We haven't asked? Anything you would impart upon young junior doctors or medical students? But if you think we've covered it all, you don't have to say anything.
Yeah.
Mm.
My suggestion would be when you go, on your anesthetics rotation, particularly as a med student, your role isn't really trying to learn skills. Like people will try to teach you how to cannulate and maybe bag, mask, ventilate, and intubate. Realistically, that's not going to help you that much, even if you end up being an anesthetist. That couple of weeks of training isn't going to make a dent in anything. What you really should be doing is trying to figure out just purely, is this a career that interests me, and can I tolerate both the positives and the negatives of this career? Everything's got negatives, but I think you should just try to be honest with yourself about what are your kind of deal breakers and figure out whether you're actually compatible with the career. I think as anesthetics become more and more hyped, there's probably more and more people committing to it without really knowing what it is, more just jumping on the train, the popularity train.
Yeah.
Which I mean is fine, but it's a long training program and then a long career. And if it's not actually what you wanted to do and you kind of just chose it because it was popular and
Mm.
it looked good at the time, you might regret your choices, right?
Would you suggest junior doctors like try sitting down and doing crosswords for like an hour at a time and then a little bit of work and then sitting down again and then
Yeah, I
and
think
then
that
maybe like day trading in between? Like, would you suggest any of those things to try and ascertain whether anesthesia could be for you?
yeah, I mean, I think these things are not as popular as what the memes suggest.
Oh, okay.
Wordle's popular.
Wordle's popular, so you should get on the Wordle.
Yeah, but it's very department specific, right? Each department's got its own kind of competition for things. So.
Yeah, yeah, yeah. You should probably rock up to work in lycra and cycling.
But actually, on that point, I think a lot of residents when they're doing the rotation with me, they'll ask me like, how do I impress people? Obviously, there's doing the clinical skills and showing some interest and having some knowledge because you've read around cases or read around
Mm.
drugs or whatever. There's all of that, but I think at the end of the day, you spend a lot of one-on-one time with yourself with the senior registrar or anaesthetist.
Yeah, you're
I
going to be
think
talking to them all like
all
theater
day,
session all day.
all day. Yeah, so I've had some residents say to me, I just don't know what to talk about with these people. And
Mm.
I mean, is kind of a red flag, right? Like if you're struggling to communicate with these people on a social level, then you're probably not going to impress them that much, right?
Yeah, yeah,
So I think, like, I say this half in jest, but I think it's probably true as well, is that you should have some interests outside of medicine and some hobbies.
100%. It makes you
Ideally, those
much more
hobbies
well-rounded.
Yeah, ideally those hobbies are hobbies that also are going to be interesting to other people when you talk about them, right? So when they ask you what you got up to on the weekend or what your plan is, you know, like I'll give you an example. Like one resident told me, "Yeah, I don't really have hobbies. My only thing is baking." I was like, "Yeah, majority of anesthetists, like everybody likes consuming baking, so you can bring in baking and they'll like it,
Baked
but like."
good.
You can't really have too much of a conversation about baking
Yeah,
my skew, right?
yeah, yeah.
So yeah, so I think having a hobby is something that you can, you don't want to ear blast people with your hobby, but
No.
having something that you can fall back to as a conversation
Yeah,
topic.
no, it's true.
Yeah,
No, it sounds silly, but it is true. You need to do things outside of our job, and you need to be able to, yeah, have a conversation because you're going to spend hours, especially in anesthetics, where it's just you and the boss.
it's one of the most unique career pathways in that regard because
It's
the
very,
training model is essentially like an apprentice training model, right?
yeah,
You learn the core skills there just through kind of exposure to somebody else doing it. But yeah, it's a lot of one-on-one time, which is good and bad, right? Like it's a great way to learn. You get to expose yourself to some brilliant people and
mm,
rack their brain for kind of ideas and ask them questions constantly. But at the same time, like it can be a long day with a personality that you just don't vibe with, right? You've got to figure out some way to survive that. And some departments are worse than others, right? Like,
Mm.
yeah. So yeah, interesting.
It is interesting.
Oh mate, that's the bane of my existence.
I thought you guys were a cannulating service.
I think it's changed dramatically like, during my training. So I remember when I was doing that internship rotation, I remember sitting at lunch with one of the anesthetics registrars, and he was holding the phone for the department, and you can kind of hear both ends of the call, right? And yeah, somebody called some intern for help with the cannula. I remember this guy saying down the phone, he's like, "You need to call the cannulating service." And you could hear the intern on the other end say, "I didn't know we had one." He goes, "Exactly," and hangs up.
Yeah.
Yeah, like people
Gosh.
used to be more brutal, whereas now you kind of are. Like, you know, a lot
Yeah.
of hospitals have the actual cannulating services now, but you know, often those are just in hours.
You know, like this is part of the negative of the job. No job's perfect.
No jobs.
Having to bail out a intern resident or another registrar from a cannula is probably one of the less desirable aspects of the job,
Yeah,
but it is part of it.
I think it's gotten worse though. I mean, no, I can't say that. Like,
If you can't
not
use the
everyone.
ultrasound, you're not gonna succeed.
Yeah, yeah. So what I would say to this is, you should definitely go and see the patient yourself. So you'll be amazed how many times we get the call. It's like you question them because like our workload is actually quite heavy, right?
Yeah.
You know, fitting in these cannulas on the ward can be really difficult. So yeah, so we try to limit it, and we ask questions like, who's actually tried? How many times have you tried? You know, what have you done to improve your chances? Things like that, right? You'll be amazed how many interns and residents haven't even met the patient themselves, right?
Mm,
So they've just had a handover from someone else, or they've heard a rumor that this patient's difficult, but they've
difficult to
never even
cannulate.
seen the patient themselves. You ask them if the patient's overweight, and they say, "Actually, I don't know." It's like, what?
What?
And invariably with those ones, you get up there and you don't need an ultrasound. Like they've got a vein.
Yeah. Yeah.
You're doing all those basic things. 100% you should do those before calling, right? And
Good
then,
advice.
yeah, I think there's some people that are just impossible or very difficult to cannulate. You know, we don't expect you to go to heroics stabbing these people, you know, when the chances are slim to none. But, you know, if you see something that you think is pretty reasonable, of course, have a go. And we're not going to be angry if you have a go, you know, a limited number of reasonable goes.